Here we go. Monday again. I don't think my voice has recovered from Therapy Expo last week. I'm still a bit hoarse. Mixing with a lot of people. It reminds me of when I used to teach at the university and all the students used to come in, and then I was ill for the whole of September and October. But yeah, hope you are all well. Morning, Martin. Good morning. Morning, Tris. Good to see some of the familiar faces in again. Um, so we've got quite a bit to get through today. Hopefully we'll finish off all the passive structures of the knee today. We've got some bits to finish off from last week as well. So I've gone over some of my notes from last week, and we didn't finish some of the bony landmarks of the knee. So going to cover those too. Hi Becky, good to see you. Good to see you last week as well. We had a good Learn Anatomy Online contingent at Therapy Expo in Birmingham, which was really good. Good to see. Right, let's get going. So this is kind of where we were last time. We were looking at the joints of the knee, and let's see else is in. Stevie, good morning, Stevie. So obviously, people who are used to being here know how to message me and all that kind of stuff. So if you are new to this, because we've had a few new people sign up recently, which is really good. So if you want to make a comment to me live, and then I can answer questions as we go, you just pop a message in the comments box, and it should pop up in my little chat box, and then I can bring it onto the screen and show everybody. If you don't want to do it live, that's no problem at all. You can do it in the group, in our Facebook group. If you think, oh God, it's a really stupid question, I don't really want to ask that out loud, then you can message me via Facebook in the group as well. So you can just send me a DM. Okay, so whatever is best for you. Morning, Penny. Good morning, morning, Maureen. How are you? Good to see you back. Didn't put you off last week then, that's good. Right, so let's get you going. Let's get rid of those on my screen. So yeah, we did all the joints. We had a look at the videos for those as well. Now we're going to have a look at the bony landmarks. Just grab my arrow here. So we did talk about these a little bit, but these are going to be really crucial when we get to the muscles, because I think I mentioned last week the reason why we've got these lumpy bits here are because of the development of our muscles. So bones, dry bones, they don't look like these pictures. They are covered in a connective tissue, and the connective tissue is it's really solid. It kind of wraps it, envelops the whole bone, and you can't get it off. Yeah, so if you try to, you kind of scratch bits of the bone off. It's properly stuck onto it, and it acts as an anchoring point for tendons. So the tendons merge into, and the ligaments as well. They kind of merge into this covering around the bone, and it's called the periosteum. And because of the really strong attachment, when a muscle contracts and you do certain activities, it will start to pull on the periosteum, so that outer covering of the bone, and obviously it's going to create some stress through that tissue. So what the body does is it fills in the that area, because it goes, right, we need to make this a lot stronger. So it fills it in with more bone, okay, and you'll get what's called osteoblast activity, or osteoblast, and the osteoblast cells are bone building cells. So anything with a blast in the name is a builder. Anything with a clast in the name is a clearer. Okay, so that's something to remember. We've got all different types of chondroblast, chondroclast, tenoblasts. Yeah, so tendon cells, tenos, chondros are cartilage cells. So the name is repeated quite a lot throughout the textbooks. You might see them done more see them more frequently. So, and that's why we get these bony lumps here. Okay, so on here on the medial condyle, so medial means towards the middle. So this will be the inside of your femur. There is a really big muscle that attaches onto here, and it's given a very big name as well. It's called adductor magnus. So it's the biggest of the adductors. It is magnus. It is huge, and it's one of your inner thigh muscles that pulls your femur in. But also, what it does is it stabilizes your whole upper body. So these are some of the actions of the muscle, because we learn actions of muscles as if they're not touching anything. So for example, if you so let's use this. So if you have your leg kind of dangling in the air and then you bring it inwards across your body, then that will work your adductor muscles. Yeah, so the adductors will contract to bring your leg across. But when you're stood and your foot is on the ground, what those adductors will do, because they attach up into the pubic region, up into the pubic bone, they will stop your body from tilting. Yeah, so they don't just move the leg; they also stabilize the pelvic girdle. So that's a massive job. Yeah, obviously taking a lot of body weight. So that's why these muscles have got really big knobbly bits where they attach, because there'll be a lot of force going through them. And if you play sports that involve a lot of change of direction, then you will have increased knobbly bits, because that is your body adapting to what you're doing. Okay, so and there was a bit of a debate because we run a sports massage company where we teach people how to do sports massage. And at Therapy Expo last week, we were hoping that these kind of things will change, but they're just not changing quick enough anyway. They will over time, I think, but there's a lot of focus on posture and postural analysis. And one of my big problems with that is you can't measure it accurately. So the kind of landmarks that we use are things like this. Okay, so when you look at someone and how they move, and you kind of mark people up with dots to see where their legs are moving, or where their arms are moving, or their pelvis, for example, we rely on these bony landmarks, but they are different for everybody. Yeah, so you cannot compare posture with one person compared to another. It is absolutely impossible. So, but it's still being perpetuated as a thing that you should do. And I think there are far better things that you can concentrate on than using bony landmarks to measure where you think someone's pelvis is. When we get to the pelvis, I did a post the other day on Movement Therapy Education Facebook page about the anomalies in the pelvis. There are loads of them. Yeah, so the marks we use at the back of the pelvis, the iliac crest heights, all of them are variable. So it's like, I don't know what it's like. It's like kind of measuring jelly. It's there's no stable thing to measure that would be consistent across everybody, and even on the same person. So from side to side, it will be different, because it will depend on what they've done. So we talked about this last week with the tibial tuberosity. Yeah, so that's where your quadriceps attach onto the tibia. And on one side, it might be really big because that is your jumping leg or your landing leg. And then on the other side, it's really smooth. And it's because the forces that you apply through that area just weren't enough to create that lump. And I mean, we don't really, well, mind you, yeah, you do. There are some measuring, like the functional movement screen uses the tibial tuberosity as a marker. And if it's different from side to side, then what use is it as a marker? It's crazy, but there we go. Things will change. Let's. You got me talking about posture. Geez, you'll get me sidetracked for hours. Base of the patella is up here. We talked about this, so the base and the apex, and it's a bit weird because the apex is at the bottom and the base is at the top, but it's to do with the shape. So we have this shape here, which is nice and flat. Your quadriceps muscles will be here, and we'll talk about those over the coming weeks. They attach into the patella, and we saw that video of the patella last week where If there was no patella, then the elastic band that they were using required a lot of energy to move the leg or the hinge not very far. But then as soon as you put a fulcrum, which is basically the patella, onto that joint line, you didn't need much force at all. So this will really help the efficiency of your quadricep muscles in order to extend the knee. Okay, so your quads will attach up into here, and then the patella sits in the tendon, and it kind of covers the whole thing, and then it comes down here into a thin band, which we're going to have a look at today, called the patella tendon, and then that will insert then onto the tibial tuberosity. So these are things that we looked at last week. So if you're not sure about those terms, then go back to last week's video and it will go through those. Quite often we will see people saying that a jumper's knee or a patella tendinopathy is to do with this region here, and it usually is. However, you can get a tendinopathy, so basically tendon problems, okay, anywhere around the patella. So it can be on the surface of the patella, it can be on the quadriceps attachment, because it is all tendon tissue. Yeah, so all of it is tendon tissue, and then it just converges onto that point. So it's more likely to be here, but sometimes when you poke and prod it, it doesn't hurt there, and it's more sore around the outsides. Okay, and what you want to try and do when you're doing a clinical assessment is try to reproduce symptoms, so that it's mainly for the patient really, so that the patient is like, yeah, that's it, you've got my pain, yeah, and that gives them then confidence in what you're doing. So give that whole patella a good old poke and a prod just to see if anything around it is sore. We've got the lateral condyle here, and then if you remember, there were the epicondyles, which means upon the condyles, and that's that kind of bony lump there. So condyle is a knuckle. Excuse me, throat is drying up already. Condyle is a knuckle, and then epicondyle is upon the knuckle. Okay, got to stop me talking about posture, and I'll save my voice. So here we go. So this is the adductor tubercle. So this is a view from the back now. This is the medial aspect of the knee, and it's that point there where your adductor magnus will attach, and we'll look at that when we have a look at that, when we have a look at the muscles. And then medial epicondyle is just here. This is the intercondylar fossa. So that means in between the condyles there's a dip. Okay, so a fossa is a dip. Intercondylar means in between the condyles. Okay, and that's that bit there. That bit's going to be important for today, because we're going to be looking at the cruciate ligaments, okay, and where they attach. And then lateral epicondyle. So this is the outside of the thigh bone, so your femur, and yeah, that area there. It's an attachment for some ligaments. Okay, so there's and again we're going to have a look at those today as well. So lateral epicondyle, medial epicondyle, the adductor tubercle. So anything where it's like tubercle, tuberosity, trochanter, all of those kind of words mean like a lumpy bit. Okay, so that is the adductor lumpy bit there, right there. Okay, adductor tubercle. Cool. Right. Oh, this is a busy one. Okay, let's start. So this is what I was talking about before. This area here. Start with something we know. This is the tibial tuberosity. Okay, so that is where your quadriceps muscles attach into. The bit we were having a feel of last week to see if one was bigger than the other. And remember we were saying if you're right-footed, it's usually the left one that is bigger, because that's the standing leg. And if you're right-handed, right-footed, you usually jump off of your left leg. Okay, it seems a bit weird. You don't really think about it until you're told about it, and then you're like, oh yeah, that makes sense. Right, let's go down the left here. So we've got intercondylar notch. We talked about that last week. Again, that's linked to the ACL and the PCL. So the anterior cruciate ligament and the posterior cruciate ligament. So there's a little raised lumpy area there on the tibial plateau, which is this. Oh, there you go, tibial plateau. So that just means flat surface. Okay. So we've got tibial plateau just there. Lateral condyle. So we've got, this is the tibia. So this is the outside knuckle of the tibia. Then you've got this one here. So that's the head of the fibula. Yeah, so your fibular bone, which we were looking at when we were doing the foot and ankle. This is the other end of it, and you can feel that quite easily as well on the outside of your knee. It can be quite tender, and there's also a nerve wrapping around it. And again, if you have a look back at the nerves of the foot and ankle, you'll see the common perineal nerve wrapping around that area there. This bit here, it's not really a point like on that arrow. It's more of a broad region, and that is something called Gerdy's tubercle. I can't remember their first name, but somebody called Gerdy named this tubercle after themselves, and it's the attachment point of the iliotibial band. So you might have heard of the ITB coming down the outside of the leg, and that is where your ITB attaches. Saying that though, it goes really quite lower than that. Okay, so it kind of attaches here and then kind of spreads out into that periosteum that I was talking about before. So it's got a very broad attachment all the way down this kind of outside of the tibia. Okay, so the lateral portion of the tibia. Shaft of your fibula. Excuse me, just here. Just get rid of that one. Tristan's going to play loads of those bloody videos again of the Fast Show or whatever it was on. Medial condyle is just here. Pezansorinus, right, that's a bit of a weird one. So that means goose's foot. Okay, so we've got this kind of web space where three muscles attach into that particular area. So this is on the inside of your tibia. It's usually very tender. So if you have a bit of a feel yourself, so feel the tibial tuberosity, this bit at the front. Move medially, so move inwards towards the midline of your body to this region here, and have a bit of a poke and a prod in there. It is usually quite sore, and there's a bursa there. We'll talk about those in a bit. There is your Sargent group of muscles, so SGT. So you've got sartorius, gracilis, and semitendinosus all attach into there. Okay, and again, we'll cover those when we come to the muscles. But that is a common site of pain for people. Okay, it's just really when you're having a bit of a feel around the leg, that quite often they're like, yeah, that bit's really sore. Okay, you can treat that area directly. It depends on what kind of treatment modalities that you have. But in terms of soft tissue work, if you do soft tissue work, then you want to have a look at the origin of the muscles that attach into here and the loading that is going through those muscles. So sartorius, gracilis, semitendinosus. So you can do certain endurance tests, muscle strength tests, and in terms of soft tissue techniques, those are the muscles that I would focus on to alleviate some of the tension here. Okay, it again depends on your skill set. Medial border of the tibia, so that's this area just here. We've got some muscles that attach, probably a little bit lower than that, to be honest, to kind of the distal third of the tibia. You might have heard of medial tibial stress syndrome, so MTSS, which is a stress fracture or the start of a stress fracture. So that medial tibial border area is a good one to feel for usually people who've done a bit too much. Okay, and they'll usually complain of pain there. Sometimes they'll complain of pain in the foot, and that's because that's where these muscles that attach here, they attach down into the foot. Okay, so again, another thing to check. But have a look back over the feet videos. Tibialis posterior is a key one for that area there. And then the anterior border of the tibia, so this area just here, that's like the really sharp bit of your tibia. So you should be able to feel that quite easily. Okay, so right on the front of your tibia bone, you'll be able to feel this really sharp ridge. Okay, so that's that one just there. And then this is from Trail Guide to the Body book. And if you've not heard of that book before, I'm sure I've posted about it in the group previously. It's written by a guy called Andrew Beale, which is Biel. It is quite expensive. It's about £60, but you will never need another anatomy book again. Okay, so God, I've bought loads of anatomy books over the years, and this is the one that I use with my patients because the drawings are really nice. There's some really cool bits in it. I think it's on the next slide. Yeah, here you go. So it gives you literally a trail guide to the body. So find the patella, drop off the patella onto the tibial tuberosity, down to the anterior border of the tibia, so the tibial shaft, and then move laterally onto the fibula head. Yeah, and it will describe how to find all of those bony landmarks, how to find Gerdy's tubercle, how to find the Pezanserine area. So yeah, really, really good book if you are, well, if you're seasoned veteran or you're just starting out. It's a good one to get. So yeah, you can only feel, the reason why I've got this image here, you can only feel certain structures with the knee bent. Okay, so if your leg is straight, you close up the joint space and you can't palpate in the knee. So, I mean, you can't get very far in anyway with the knee bent, but what you will be able to do is feel the front of the tibial plateau, and that is where your meniscus sit. Okay, so sometimes you can have a good old poke and a prod in there. Now, had a chap this morning in, and his son's just had a knee injury playing rugby. And when he described it, I was like, oh, uh-oh. I think he might have done his meniscus, hopefully not his ACL. But his knee is like the size of a bowling ball. It's just completely swollen up. You can't see his kneecap. So sometimes you get, if they've immediately had an injury, the swelling will just go boom. And the problem is then you can't feel a thing, because the swelling is there for a particular reason. It is to stop you moving it, to protect it. And then eventually the swelling will start to dissipate. And even then you can't have an MRI because there is too much swelling so that you can't see anything on the imaging. The imaging is really poor. So you have to wait until everything calms down and then you can get the MRI done. And that's what's going to happen with this kid. He's I think he's due. Well, they're going to check it over the next kind of week or so. But he plays for a pro rugby team, so they've got an MRI scanner, so they can do it whenever. But yeah, they'll wait until that swelling comes down, then they'll image it so that they can see the structures in the middle. But if it swells up like that, it's usually something nasty. Okay, hopefully it's not, but usually it is. So unfortunate. But that's rugby for you. Okay, right. Let's just do this one. Cool. So that was our recap of the bones. We're now going to go on to the passive structures of the knee. And the reason why I've called them passive structures is because they're not active structures. Okay, so you've got passive tissue and active tissue. The passive tissue can't contract. Okay, the active tissue can. So active tissue is basically the muscles and then the tendons that attach onto those muscles. The passive structures are things like your cartilage, your ligaments, your bursa, all the connective tissue bits. Okay, but it doesn't mean that they don't do any kind of important jobs. Yeah, that they do some really important jobs. Some of them guide movement. Some of them are completely full of little receptors. And what those receptors do is they alert your spinal cord and then up to your brain where the structures in your body are. Okay, so when you're moving, you'll put a stretch. So for example, the ligament tissue are crossing over joints. So if a joint is stressed in a particular way and it's stretching that ligament, that will be picked up by these little receptors. They're like the way that they're described in the textbooks is like a coiled spring. Yeah. So if you imagine, like, normally they would be like just under resting tension. If the joint gets moved out of its normal range, so like with this lad, then the springs will get stretched. Once they get stretched to a certain point, that will then fire off a neuron, which will go to the spinal cord, up to the brain, and go, that ligament in your knee on the inside is being stretched really quickly. And then immediately you'll get a reflex action in like nanoseconds to contract the muscles that cross the joint to protect the joint. Okay, so that's in an extreme example of when you might be potentially getting injured, but they also work normal day to day as well. So when you're walking down the street, your body will sense where your joints are from the feedback from the ligament tissue, so that your muscles can coordinate themselves to try and stabilize your leg and make sure that your knee's in the right place, basically. Okay. The stronger you are, the fitter you are, the better those proprioceptors are. Yeah, so if you don't use them, you will lose that feedback, and the reaction time for you to be able to stop like weird movements that might injure the joint. Those reaction times will be reduced. So you need to keep training them so that they can respond. Yeah, it's really, really important all the way through life. Even you can have proprioception benefits even in the kind of 70s, 80s, 90s. Even if you've never done any weight training before, you can build up the sensitivity of those areas to help protect you and increase your reaction times. Yes, and really, really important stuff, especially for older adults. No problem. Oh yeah, Bob Fleming, that was it. Right, let's have a look. Got a few questions here. What are the pain symptoms when patella issues? It can vary. It depends where the problem is, Martin. So it could be sometimes just tenderness on palpation. So when you push it, it's sore. Sometimes when you load it, especially if you go like put a lot of load through the knee in like a forward lunge position. So there's no problem doing that position and the old knees over toes and all that. That's fine. But sometimes when the tendon is overloaded, it doesn't like it. So you just protect the tendon a little bit by not doing that movement for a little while, and then gradually start to introduce it again. Okay, so it might be like an achy feeling. If it's quite sharp and catchy, then there may be some kind of bony change. Okay, so it depends, that one. Yeah, Bob Fleming, I remember that. Yeah, thanks guys. Abe, no worries, good to see you. I still use the overstretched curtain and the broken cords and the tape at the top. Yeah, perfect. Yeah, so that's a good analogy. Yeah, so the kind of pleated curtains. Good. Cool. So let's have a look at some ligaments then. So we've got collateral ligaments, which are these ones here. These are on the side of the knee, and you've got them in various different places in the body as well. So we've got them in the fingers. So you've got collateral ligaments either side of your joints in your fingers. You've got collateral in the knee. You've got them in the wrist. You've got them in the elbow. Okay, so that's why calling it the medial collateral ligament, we often call it that, and it refers to the knee. Everybody kind of knows the MCL, the medial collateral ligament is to do with the knee. The problem is we have an MCL in the elbow. We have an MCL in your fingers. So really, you should call it related to the bones that it attaches to. So sometimes it's called the tibial collateral ligament, and you'll see that on some of the videos. But most people call it an MCL, and we know it's to do with the knee. Okay, so this ligament is really broad and flat. Okay, but it's got a couple of slips on it, so it kind of fans out a little bit, and yeah, it slants anteriorly, so towards the front, and is longer than the LCL. And you can't see the extent of it on this picture here, but it goes down a far way down the tibia. Okay, quite far. Protected by the pezanserine tendons. So we talked about those. Those are the ones that go over onto the front of your tibia. Attaches to the medial epicondyle. Here we go. So the bony landmarks are coming in useful. So there's your medial epicondyle up there. So that's what we were just looking at earlier. It also attaches to your medial meniscus and medial tibial condyle, upper medial shaft of the tibia. So it's kind of like broad, flat, yeah, across the middle of that joint. The problem with it is if you open up the knee on this side. So, for example, and I think this is what happened with this lad. He had his feet planted and then he got tackled from the side. So his knee basically went like that. Get on camera like that. Okay, so it opened up the inside of his knee, which then stretches your MCL. And because it's attached to the medial meniscus, you often get meniscal injuries as well. Okay, and usually because of the action that is occurring, so it doesn't just go that way, but it also goes that way and then twists. That's just what happens usually. Then you can injure your ACL as well, so your anterior cruciate ligament. So you can do all three with a kind of bending, twisting motion where the knee comes in. Okay, especially if someone is sort of 18 stone hammering into the to the side of your leg, then and your foot is planted and you've got studs. So, and that's the thing with things like rugby and football, you've got studs in your shoe, which are great because they can give you lots of control on the grass. But when your foot is grounded and you're smacked, then your foot can't slide, it's stuck. So your whole body twists around your foot being stuck, and that's why you tend to get injuries in those sports. We've got superficial and deep portions, and they've got different roles. The superficial fibers are the tibiocollateral ligament, and then the deep posterior fibers are the posterior oblique ligament. So you can see it's like at an oblique angle, yeah, just there. What they do is they restrain valgus, which is that. Okay, so basically the knee coming in is a valgus position. Right, they help prevent lateral rotation, so a movement of the foot externally. Excuse me, hyperextension and tibial translation. So basically the tibia sliding, okay, forward and backwards. So they have a stability role. Okay, that's basically what they do. Just a couple more comments in here. Let me just pop this one up. So General Medical Council offer guidance or movement and exercise for the different age groups. I use this to try and engage people who aren't doing enough. Yeah, brilliant. Yeah, it's honestly like we get people in their 90s lifting weights for the first time, and they struggle with the gardening, they struggle walking, and they feel a bit isolated. And then even after just a few weeks, because in a few weeks you get all these neurological changes, because it kind of wakes up their proprioceptors again, and they're able to do so much more. Architectural changes in the muscle take at least 3 months. So you have to do consistent weight training, overload type training, and obviously that differs for everybody, for at least 3 months for the muscles to change. Yeah. So all of those changes you get early doors, they are majority of them are neurological. And the problem with that is if you do 2 months of strength training and then stop, then you'll lose it quite quickly. Yeah, because the architecture of the body hasn't changed. Yeah, so to get those architectural changes, you need to keep going and keep going and keep going, and it should become hopefully part of daily life. Guess speed of joint movement with the force applied is the thing. Yeah, exactly. So that's a good point. So valgus knee is not a problem. Yeah, because if you need to change direction in a sport, then you have to allow your knee to come in and rotate around that knee. So you need to train it, and that's. But obviously, sometimes you can't move and you get hit, and it's just traumatic. There's not a lot you can do. There's no such thing as injury prevention. So if there is a program out there that you see or a course that says that this course helps to prevent injuries, then unfortunately it's a lie. You can reduce the risk of injury, but you can't prevent them because you have no idea where they're going to come from. Okay, you don't, like, especially in a sport like rugby or football. where you're getting tackled and hit, like any kind of impact sport, martial arts as well. Yeah, you can't say this will prevent you getting these injuries, because you have no idea what's going to happen, but you can reduce the risk. Okay, so it's a very subtle difference, but it's really important. That's brilliant, Tris. Yeah, starting, I guess, in starting deadlifting at 75, that's brilliant. Yeah, I wish my mum and dad lived closer to me, because I would get them weight training every day, definitely. Right, enough of me warbling on. Let's have a look at these. Just go to this one. Okay, cool. So this is, this is both of them. Right, let me do the next one and then we'll do, okay, so this is the lateral collateral ligament. All right, so see that one there? There's your fibular head. Just move me out of the way. And then that is your lateral condyle and lateral epicondyle. So this is shorter than the MCL. Okay, so you can see that there. If we just go back one, see that there? That's really quite broad and goes really far down the tibia. Yeah, this one quite short. Yeah, and sometimes you can feel this one. It depends on the kind of extent of muscle tissue you've got on the side of your leg. It slants mostly posteriorly from the lateral epicondyle to the head of the fibula. So again, hopefully these terms are starting to make sense now. So there's your lateral epicondyle, and then down onto that fibular head, just there. Separated from lateral meniscus by the popliteus muscle. So this doesn't attach to your meniscus, not like the MCL, which is like bound to it. There is a gap, and you'll see that in a second on the video. It's surrounded by the tendon of biceps femoris as well, which is one of your hamstring muscles, and it tightens in full extension. So when your leg is fully extended, it locks the knee. Okay, so it keeps it in position. And what this will do is it will restrain varus movements. So valgus is where your knee comes in, varus is where it goes out. And the way that I remember that is if you're bow-legged, like Mum used to look like walking like John Wayne, then you've got air in between your knees, causing your knees to go out like that. Okay, that is varus. So varus with air, and then valgus coming in, knees knocked. Okay, so knees knocking in is valgus. Air between your knees is varus. Okay, so that's those two. Right, let's have a look. Here we go. So there is your fibular head. Let me just pop that there. And you'll see on the videos here, they've called it the fibular collateral ligament, which is probably the proper term, because it attaches to your fibula and up onto the femur. You see that squidgy bit of tissue there? That is meniscus. Okay, so here's your tibial plateau, just there. That is the condyle of your femur, and you can see the difference here. Can you see that bit there, where the tissue is different to here? That's the cartilage of the knee. Yeah. So that is like this, when it's in good condition, it's like the slippiest of surfaces, so smooth. Okay, it's really quite amazing when you see a good one. So fibular collateral, you can see it's not attached. Let me just go back a bit. It's not attached to anything here. See, there's a gap. Excuse me. Really sorry. Yeah, not. I'm trying to stop myself from coughing all sorts today. So we've got lateral epicondyle just here, fibular collateral or lateral collateral ligament, and then attaching onto the fibular head just here. And so if this one gets injured, the only thing it's going to injure is this. Yeah. Here's the MCL coming in. Look how flat that is compared to that one. So that one's like a like the well, it's kind of like the width of your little finger. Yeah, so it's that kind of thickness. Whereas this is really flat, but look how low it comes, all the way down here. So tibial tuberosity is around here, and it's coming all the way down there. So sometimes your MCL can give you grief on that medial tibial border, and it's actually just a strained MCL. Yeah, so all the way down there, and you can see how it merges into that periosteum that we were talking about before. But here's your medial meniscus, so the inside meniscus, and we haven't talked about them yet, but just to introduce these, and you can see it's firmly attached to it. Yeah, So it's solid on that inside. Yeah, and that's perfect. Yeah, chicken legs have got great cartilage. Yeah, so if you open up apologies if you're vegetarian or vegan, if you open up a chicken leg, you can see it's just glistening white with cartilage. Okay, so it's exactly the same as ours. Looks exactly the same. So there's your tibial collateral or medial collateral. Yeah, condyle of the femur, so this will be your medial condyle. There's the epicondyle, there's the adductor tubercle that we were talking about before, and that just covers that. It's kind of like I said, it's like slapped on in between the joint surfaces, and it attaches to your medial meniscus as well, just there. Okay, there it is. Okay, so there's the attachment point, medial epicondyle onto the anterior medial border of the tibia. But again, not just on a point, it's kind of like merging into everything. So the MCL, yeah, here we go. And I think we've got it on the next video. I'll show you the next one. What time is it? Yeah, I'll show you the next one as well, because that will help things make sense. But the MCL blends with the knee capsule. So the knee doesn't look like this. They've taken some stuff off of it. There's a capsule that surrounds the knee. It's like a ball covering, yeah? And that protects your knee joint as well. And it's got a synovial fluid lining. So when you move it around, it releases fluid into the joint so that it maintains the lubricancy of the joint, yeah? And it keeps everything moving. They've taken the capsule off of this so that we can see inside, all right? But I'll show you the capsule in a second. So that's where the capsule will attach to, and look at it there. So it's connected to the medial meniscus just there. Yeah, just solid connection. And just in there, just about there, you can start to see the cruciate ligaments coming through. Okay. Fibular collateral, so there's your fibula head. And again, look how thin that is compared to the MCL. Yeah, so that was not connected to the meniscus. I'll bring in your question in a sec, Penny. Bear with me a second. So there you go. You can see there's a clear gap. Yeah, here we go. So extension of the knee will tighten the collateral ligaments. Okay, so when the knee goes straight, that's when everything tightens up. So let's just go back a sec and have a look at that. Okay, so here we go. So if you watch it, yeah, so extension and then really taut in that position. Flexion, and they'll go loose. So this is why if you land, knee bent, twist, that's when you get problems, because the ligaments are loose at that point, and especially if you get hit at the same time when you're in that position, they lose a bit of their proprioceptive function. Because remember I was saying they're like coiled springs. Yeah, so if they're slightly squished, that means they've got to go a lot further to get that feedback to go, whoa, we're being stretched here. Okay, so you don't get that feedback until it's too late. And that's why you usually get injured bent knee twisting, okay, because the ligaments are loose and you're not able to get that feedback as quickly as you would if the ligaments were dead straight. Cool. Okay, let me bring that question in. So if a person was struggling with inside knee pain, would you look at the hips automatically for the adductor origins? Only if the it looked as if it was coming from the Pezan-Serine area or the adductor tubercle. I'd also be thinking about medial meniscus, osteoarthritic changes to the knee, maybe quadriceps. So kind of having a look at all the structures that are on that medial aspect as a priority. And then depending on where the symptoms were, then I would start to look a little bit further afield. Yeah. Right, let's have a look at this one. So last one for today. This is the joint capsule. So this is what it looks like. They cut all the joint capsule off of the last one so we can see inside the knee. So here is the patella, and look, there's the patella tendon. Yeah, it just completely covers the whole of the knee, the whole of the patella. and then there is your capsule. Okay, so the capsule attaches to the medial collateral. So there's the medial collateral ligament, the one we were just looking at. Just move that arrow out of the way. But you can't see the meniscus now because the meniscus are in the capsule. Yeah. Capsule separate from the LCL as well, so there's a gap there. And then look at the back of the knee as well. Yeah. So the capsule thickens. Can I get that back? Ooh. Hold on, my arrow's got stuck in the corner. There we go. Capsule thickened at the back to help prevent hyperextension. So that means the knee going too straight, so going too far the other way. So there's not much give at the back here to help prevent that hyperextension at the back. And I think, there you go. So that just shows that. And I think they cut it in a set. Yeah, here we go. Look at that. Okay, so the capsule is lined with a synovial membrane. So they've put a cut through the capsule and then you can see inside. So all of the inside will be glistening with synovial fluid. Okay. There it is there, look. Look at that. Obviously that flap is not normally there. It would normally be quite sealed. But so this is why we have conversations with patients all the time. Should I get this done? Should I get that done? And I would always err on the side of caution with any kind of surgical procedure, unless it's absolutely necessary. And sometimes it is, because once you've gone in and you've broken the seal, then it can cause some problems later on down the line. I think if you can minimize disrupting this kind of tissue with all the sensible lifestyle and strength and conditioning advice, even with ACL ruptures, ACLs can regrow. Yeah, we're going to talk about that when we get to the ACL, because that's amazing. Cruciate ligament covered in synovial fluid. So here's the cruciates. So they've taken part of the capsule off there, so you can see inside. But look at that; it's just full of fluid. Yeah, full of fluid at the back there. Cool. Are capsular tears possible without other injury? Good question. Probably not. It'd have to be pretty traumatic to tear the capsule. So you would imagine that there would be other unless it was like it's kind of impact injury with a sharp object or something like that. But yeah, any kind of twisting motion, the ligaments would go before the capsule. Yeah, because the capsule is quite flexible. It has to be so that the knee can move about. But the ligaments aren't so flexible, and they're slightly different tissues as well. So they'll have you're going to have more elastin in the capsule, so that it's a bit more flexible. Okay, good question. Cool. I think that will do for today. So, passive structures of the knee, part 1, done. So yeah, had a look at MCL, LCL, or tibial collateral and fibular collateral ligaments, and I've had a look at the joint capsule as well. So we'll do a bit of a recap on those next week, and then we'll go into the ACL and the PCL. There is a really good Facebook group that I'm part of. I'll see if I can find it, and I'll send you guys the link, because it's an ACL recovery group without surgery. And we've had a couple of patients at the clinic where they've had no surgery, and their ACLs were ruptured, and all we did was rehab the hell out of them and got them really strong, and they were back playing sports, they were back skiing, doing normal things again. Okay. Yeah, just got their life back, and they were going to go for surgery. We hammered their rehab, and then when they went for their pre-op, the surgeons were like, whatever you're doing, keep doing it, because we won't be able to get it any stronger by doing the surgery, so you may as well just keep doing what you're doing. Okay. Cool. Right, I'll see you next week, guys. What time is it? Yeah, 10 to. See you next Monday, 10 o'clock. See ya.